Hi, this is Terry Kuti. We are continuing our discussion with Dr. Roy Kim, a plastic surgeon here in San Francisco. And Dr. Kim, I want to discuss pain management with you as it relates to breast reconstruction, whether implant-based or say like a deep flap, autologous based, which is what I had, because opioid crisis, it's on the forefront. Kind of go through the pain management process with us after breast reconstruction surgery.
So before surgery, it's important to know exactly how much pain you're in. So by that I mean some of you may already be having back pain, other issues with pain medicine. You want to talk to your doctors about this because you are going to have a big pain problem with breast reconstruction, and you want to be braced and ready for it.
Yeah, and I never thought about this because I didn't have any of those issues before, but there are women who go into surgery that are already having pain issues that have nothing to do. Very good point. Thank you.
That's totally correct.
Yeah.
And then near the end of the surgery, we will typically give you long-term numbing medicine. Either we inject it into areas of your surgery, or we give you a pain pump where it's dripped in. It's the equivalent of me as a doctor hanging out at your bedside and giving you a shot of numbing medicine like once an hour for the next 3 to 5 days. Of course, I'm not going to do that. However, we have devices that can actually simulate that will replicate that.
So what you're saying is intraoperatively, when you are opened, they inject a long-acting
medicine, and also we can put in pain pumps, which is like a tiny little IV tube attached to a big balloon, and the balloon squeezes out slowly over 3, 4, 5 days, numbing medicine right to where you just had surgery.
Are those called, I had one of those after my mastectomy, and I forgot the name of it.
PCA, patient-controlled analgesia?
Yeah, it was something else.
Yeah.
Anyway, go ahead with your conversation.
Oh yeah, no, there are lots of nerdy terms that I could throw at you. So. Anyway, and then after that, you're going to be on narcotics possibly or probably for a couple days.
Mm-hmm.
In theory, as surgeons, we would love to get you onto NSAIDs, non-steroidal anti-inflammatory drugs, stuff like Celebrex or ibuprofen or aspirin or equivalents, or a couple different types.
Mm-hmm.
They induce bleeding. So this is why typically we recommend and we'll tell our patients, wait a couple days. I'll give you the green light as to when you can start taking those.
Okay.
The NSAIDs help reduce pain and swelling, which is why we like them so much.
Mm-hmm.
The other two things which help are muscle relaxants and or nerve blocking agents or nerve agents. So in other words, depending on where the implant's placed or below the muscle, deep, flat, and how much muscle pain you're in, a muscle relaxant will help.
Mm-hmm.
Things that reduce nerve pain transmission also help as well.
Yeah, so a couple products, like I know with my deep flap, you know, there's the adjustment period where you're bent over and you gently, you know, straighten your posture. So I think what that does is put that added pressure on your back. So I was given muscle relaxants really for my back, and it really helped at night. I think the important thing too, from what I'm hearing you say, is that patients need to be aware of their pain. They need to be aware of their pain threshold, stay ahead of it, let their doctor know about it.
Yes, absolutely.
Okay. All right. Good information. Thank you very much.
No, you're welcome. Thanks for having me.
Absolutely.